I'm going to be talking about the clinical spectrum of liver disease in Africa, and hopefully this will set the scene for the talks that we're going to hear over the next 3 days. So in Africa there are 54 countries, 6 in North Africa, and sub-Saharan Africa is divided into the western, eastern, southern and central regions. There's a total population of 1.3 billion, and this accounts for 16% of the world's population, and 40% of the population is actually urban. But what we can see, if we look at the socio-demographic index, in fact, majority are low or low middle, and very few are in the upper middle indices. So in WHO Africa region, the low-income countries, the per capita gross national income is less than $1,600, with total health expenditure of 5.5% of the GDP. WHO per capita expenditure is $83, and this is less than 2% of the average spend in high-income countries. And this obviously has an impact in terms of healthcare delivery. It's estimated that there are only 2.7 physicians and 12.4 nurses per 10,000 population. And this contrasts with a worldwide average of 13.9 physicians and 28.6 nurses. Even worse is our ability to provide adequate surgical care, which at low-income countries 0.7 and 5.5 in low-middle income providers per 100,000 population, contrasting very poorly with 22.6 and 56.9 per 100,000 in upper middle income and high income countries respectively. And in addition to this, there are a number of different climatic zones throughout Africa which has obviously an impact on infectious diseases. So socioeconomic factors affecting health expenditure, access to healthcare, as well as climatic factors all affect the spectrum and severity of liver disease that is seen in Africa. So we look at the spectrum of disease, the well-known entities of viral hepatitis, HIV and liver disease, alcoholic liver disease, NAFLD, and drug-induced liver injuries are all seen, but there are some interesting factors associated with all of these etiologies. We do see a propensity of infections such as schistosomiasis, ascariasis, and hydatid, and then we have this interesting entity of membranous obstruction of the IVC. And in terms of the more rare diseases like autoimmune liver disease and metabolic, these are probably seldom diagnosed and are missed. And one of the other problems is this lack of adequate data. Mortality estimates in Africa are largely based on verbal autopsy data, with the majority of the vital registration data coming from Southern Africa and Egypt. This is a relatively old study from the Global Burden of Disease in 2010, but what you can actually see that majority is due to hepatitis B, C, and alcohol, both for cirrhosis, mortality, and HCC. But what is concerning in cirrhosis, up to 31%, this is put down to other, and 11% for HCC. And this probably reflects a number of factors: lack of diagnostic ability, lack of data, but also patients often presenting in pre-terminal stages. So we all know about the burden of viral hepatitis in Africa, and the WHO Africa region really has been trying to address this in detail. Hepatitis B is endemic, affecting 5 to 8% of the population, mainly in West and Central Africa. Hepatitis C estimated in 19 individuals who are infected, and the viral hepatitis is a growing cause of mortality amongst individuals living with HIV. Approximately 2 million were hepatitis B co-infected, and 500,000 who are hepatitis C co-infected. But we remember these are all estimates. Hepatitis D is endemic, but they're very poor natural history data, as we'll see. And hepatitis B is endemic, but there are also large outbreaks have been reported. So recognizing the real burden of viral hepatitis, there are a number of service targets that were actually put forward by WHO Africa by 2020. But remembering we're now in 2018, and we're probably not achieving this. 47 countries should have developed national action plans. HIV vaccine coverage amongst infants and healthcare workers needed to be 90%. And at least 25 countries should have introduced the birth dose vaccine, with all countries testing blood transfusions. 50% of injections need to be administered with safe devices, and at least 200 sterile needles and injections should have been administered to injecting drug users per year. In terms of diagnosis, 20% should have been diagnosis, 1 million treated for hepatitis B, and 300,000 receiving hepatitis C treatment. But as we'll see in the following slides, we're falling well short of this. In terms of mortality for viral hepatitis, the mortality ranges varies across the region, the lowest in Southern Africa at less than 10 per 100,000, and the highest in West Africa at greater than 33.5. And this slide shows the real burden of morbidity associated with hepatitis B, and hepatitis B and C, particularly hepatitis B, across the region in sub-Saharan Africa. So as we know, 60 million are estimated to be infected with a prevalence of 6.1%. And unfortunately, this prevalence is really established early in childhood, particularly in West Africa, where we see that very high prevalence. So these infection rates really reflect our inability to adequately address maternal and healthcare programs in order to prevent mother-to-child transmission and this early childhood acquisition. So if we're going to have any impact, we need to really address horizontal transmission from close household contacts, medical and traditional scarification procedures. And this is a real problem. A Gambian phylogenetic analysis study showed hepatitis B transmission occurred within 2/3 of families. Perinatal transmission is a problem, and particularly aggravated by HIV co-infection. But we need to remember that a number of adults who were born pre the introduction of the vaccine into the EPI, and they still remain at risk of acquiring this sexually. And if they acquire HIV as a co-infection, there's an increased risk of acute liver failure. Unfortunately, percutaneous transmission with needle stick injuries, unsafe injection in medical practices, as well as blood transfusions, are still an important source of transmission. So in hepatitis B, as we know, the surface antigen prevalence is higher in rural than in urban areas, and this provides further economic burden on under-resourced healthcare services. The greater risk of males acquiring it, and this increases with age, and 30 to 50% of Africans infected in early childhood remain surface antigen positive, but only 10% remain E antigen positive during their adolescence, and they're thought to lose the E antigen at an annual rate of 14 to 16%. So more than 85% of those who have biochemically and histologically active disease are E antigen negative, further emphasizing need for a quantitative hepatitis PCR. Studies from the Gambia have shown that male sex, maternal surface antigen status, genotype, aflatoxin exposure, E antigen status, viral load, and ALT levels were independent predictors of fibrosis. But the full beneficial effects, even if we implement this, of birth dose vaccine and immunal vaccination, is going to take several decades. So we have a large reservoir of chronic hepatitis B in Africa, and we need to diagnose these individuals and link them to care. The recent published Polaris study shows we're really not achieving this. Only 1.5 million have been diagnosed, or equates to 2%. 33,000 have been treated, or less than 1% accessing therapy. 1 million children are still positive for surface antigen with a prevalence of 3.4%. Remembering we're aiming for a prevalence of less than 2% in WHO Africa. And only 90% of countries that introduce the birth dose vaccine, and only 10% have a timely vaccination. So we're going to upscale diagnosis and link to care. We need affordable diagnostics with point-of-care testing, which we're going to hear during this meeting, as well as access to DNA quantification. But importantly, we need long-term follow-up and sustainable access to antivirals for those who are mono-infected. HIV co-infection has a further impact. This increases mortality and morbidity. It's associated with increased hepatitis B replication, reactivation. Mother-to-child transmission is increased 2.5-fold. There are increased rates of occult hepatitis B, chronicity of newly acquired infections, and progression to fibrosis and cirrhosis is estimated to be 5 times faster, with liver cancer occurring at a younger age and is often more aggressive. HIV co-infections are another problem. They tend to outnumber the hepatitis C co-infections. They have a higher mortality, and this is particularly a problem if they have low CD4 counts less than 200, where the risk of death is 16 times higher compared to CD4 counts of greater than 350. And we need to remember that many individuals in our region are still presenting with CD4 counts less than 100. In terms of mother-child transmission, we know E antigen positive women, the pooled risk without prophylaxis is about 40%, so that although this is lower than the risk associated in Asia, and in E antigen negative women, the pooled risk without prophylaxis ranges at about 4%. But this is still a significant problem. If we look at the estimated number of infants who are perinatally infected each year, this is twice that of HIV. HIV is routinely screened, but many countries are still not screening mothers for surface antigen. So moving on to hepatitis C, in terms of the North Africa, Middle East prevalence, the overall viremic prevalence is 1.7%, one estimated 8.5 million being infected. And this is majority from Egypt, where it's a 6.3 prevalence, one estimated 5.5 million. And in sub-Saharan Africa, the overall viremic prevalence is thought to be 1%, with 11 million being infected. Of note, across sub-Saharan Africa, it varies, with the lowest in East Africa at 0.5%, the highest in Central Africa, 2.1%, with the greatest number of individuals being affected in West Africa at 5 million. Data is scarce on high-risk individuals such as MSM and injecting drug user as a result of cultural biases and criminalization, and there are very few accurate data on MSM. In Sudan, it's been reported being between 0.1 and 1%, and in South Africa, from our own centre, we've reported 3% in HIV-negative MSM and 6% in HIV positive. In terms of transmission, we know the new infections globally are usually a result of injecting drug use or MSM, but transmission in Africa varies in a number of aspects. Traditional practices have played a role with circumcision and scarification rituals using reused instruments. Iatrogenic sources, unfortunately, were a major problem. If we look at unsafe blood transfusions in the late 90s, only 19% of blood was screened, and the risk of acquiring hepatitis C from blood was 2.5 per 1,000 units transfused, compared to 1 per 2.3 million in high-income countries. Of interest, in 2016, 40 WHO countries now report actually testing 100% of their donations. But unfortunately, there's still inconsistent confirmatory testing on blood donations across many regions. Unsafe injection practices account for 3.7% in the WHO Africa region as a result of reused needles, syringes, and injection overuse. And things that have played a role are vaccination campaigns and parental treatment campaigns to eradicate schistosomiasis and trypanosomiasis. And we still have lack of access to affordable reuse prevention devices. So as we know, in Africa, it's a pan-genotypic from 1 to 5. In Central Africa, it's mainly genotype 4. East Africa, genotype 4. In Southern Africa, we have a predominance of genotype 5A. And West Africa is interesting, genotype 1 in Nigeria and genotype 2 in Ghana. And in North Africa, as we know, genotype 4 predominates. But what about access to therapy? In fact, we're doing even worse with hepatitis C than with hepatitis B. In North Africa, 5 times more people are achieving SVR than new infections, so they have a 5.9% positive net cure. But unfortunately, in sub-Saharan Africa, the negative cure is negative 2%, and 34 times more new infections are occurring than cures. So we're going to be addressing this. We really need to diagnose, but we need to get access to affordable DAAs. If we look at co-infection with HIV hepatitis C in sub-Saharan Africa, 19% are estimated to be co-infected, or just under 430,000 cases, with a median prevalence of HIV infection, excluding injecting drug users, to 1%, or 360,000 cases. In North Africa and Middle East, this accounts for 2% of the HIV and hepatitis C co-infected population at 53,000 cases, with a median prevalence of 4% if we exclude injecting drug users. If we look at the injecting drug users in more detail, globally, it's thought that there are 15.6 million aged between 5 and 64 years, accounting 0.33% of the population prevalence. And in sub-Saharan Africa, it's estimated there are 1.3 million injecting drug users, or 0.28% of the population prevalence of injecting drug users. In North Africa and Middle East, there are 350,000, accounting for 0.12% of the population prevalence of injecting drug users. And this is going to have an impact in terms of long-term morbidity or mortality, particularly in terms of developing cirrhosis and HCC. So we look at the prevalence of HIV, surface antigen and antibody C prevalence. In HIV, in sub-Saharan Africa, the prevalence is 18.3%. In Middle East, North Africa, 36%. And this compares to a global prevalence of 27%. If we look at hepatitis C, the prevalence in sub-Saharan Africa is 21.8%, 48% in the Middle East, and 52% globally. And for hepatitis B, 3.7% in sub-Saharan Africa, 8% in the Middle East, and 9% globally. So as we can see, the global mortality and burden of cirrhosis and HCC is increasing, and this is particularly going to be a potential problem in Africa as the injecting drug user population increases and ages as well. Moving on to hepatitis D, this is an interesting virus in that it tends to be more prevalent north of the equator. The overall pooled seroprevalence is thought to be just over 8% in sub-Saharan Africa, accounting for 0.7% of the sub-Saharan population, or 7 million being infected. It's lowest in East and Southern Africa at 0.5% in the general population, and highest in Central Africa, where it's 25% of the general population and 37% in liver disease populations. And the reported data from Egypt ranges from 5 to 58%. As we know, this is associated with accelerated progression to cirrhosis, increased incidence of HCC in hepatitis B infected individuals, but unfortunately natural history has not been reported from African populations where genotypes 5 to 8 are actually specific to the continent. Methods of RNA detection need to be standardized, but we also need to consider the eligibility of antibody and RNA testing in African settings. But we need to remember that the odds ratio of developing or being hepatitis D antibody positive is 5.24. In surface antigen positive, we present with liver fibrosis or HCC relative to their asymptomatic controls. So I think this is an entity we need to consider in individuals who are hepatitis B positive, who are virally suppressed and compensated, who then deteriorate. We need to be aware of this potential co-infection of hepatitis D. Looking at hepatitis E, it's mainly genotype 1 and 2. Large outbreaks have been reported from Sudan, Chad, Uganda, Kenya, Somalia, often occurring in refugee camps where there's overcrowding and poor access to clean water and sanitation. And it's associated with a high mortality and morbidity, particularly in individuals who already have other coexisting liver diseases such as hepatitis B and hepatitis C. Unfortunately, there's lack of available and affordable diagnostic serology and molecular testing, and the vaccine is not widely available and has not been tested in the African setting. And then this entity of HIV liver disease, which we definitely see. We can look at this in terms of the pre-ART era, where mainly opportunistic infections, viral hepatitis, HIV cholangiopathy and malignancy. And then the post-ART era, where we're looking at immune reconstitution syndromes, long-term complications of viral hepatitis, increasing the metabolic syndrome, and drug-induced liver injuries. But as I've mentioned, many individuals in sub-Saharan Africa are still presenting with CD4 counts less than 100, so we're seeing the whole spectrum of liver disease that is associated with HIV. From our own center, which is a high HIV burden area, Mark Sonrab looked at the clinical pathological assessment of 300 patients with HIV/AIDS. The median age was 34 years, 76 were Black African patients, and the median CD4 count at the time of biopsy was 127. The most prevalent biopsy finding was drug-induced liver injury at 42%, followed by granulomatous inflammation at 30%, and 50% of these had evidence of TB iris. Fatty liver disease was seen in 19%, Hep B co-infection in 19%, Hep C in 3%, but importantly, 16% of individuals had more than one pathology. So we look at the multivariate analysis on the study. Cotrimoxazole, as expected, was associated with a cholestatic or ductopenic injury, but an interesting finding was efavirenz, which was associated with non-specific hepatitis, but more concerning as submassive necrosis, which was associated with a younger age. The leading opportunistic factor in our patients with TB, and I think in our setting, liver biopsy really was an important investigation to have to establish diagnosis, particularly when 16% of individuals were presenting with more than one diagnosis. And this, unfortunately, is not easily available in many regions within our country, as well as across the continent. So having realized that efavirenz, there was a concern about efavirenz causing submassive necrosis, we undertook to look at this in more detail. And there was 81 patients, 50 retrospective and 31 prospective, who all met criteria for efavirenz DILI. The median age was 34 years, 73% were female, and the prospective group, 58% were pregnant at the time of initiating ART. The median CD4 nadir was 348 cells, and the median duration on ART was 20 weeks. 3 patients had hepatitis B, but the biopsy showed no evidence of active hepatitis B, and the finding was due to DILI. So if we look at the 3 histological patterns, there was non-specific hepatitis, mixed cholestatic hepatitis, but this concerning entity of submassive necrosis, which was associated with grade 4 elevation of transaminases, severe jaundice, and coagulopathy. And this on biopsy had, as you can see in the slides below, immunologic pattern with inflammatory intervals showing lymphocytes, plasmas, and very conspicuous intervals, and then marked submassive necrosis with collapse of the liver, and these patients tended to have quite a poor prognosis if they were picked up late. So multivariate analysis for submassive necrosis, the CD4 count of greater than 350, female gender, and interesting, an age greater than 30 was protective. The median length of stay was 28 days, but you can see it ranged between 11 and 60, and the overall mortality was 11%, and 19% in the prospective group. Most of the deaths occurred within 1 week of presentation. In those who presented with submassive cirrhosis, they were treated with steroid therapy. In terms of alcohol, we can see both the female and males, there's really a wide range of intake, and this is influenced by culture and religious beliefs in the different countries. But importantly, both in males and females, the age standards death rates due to cirrhosis are significant, and this is something that we need to address as a region. Obesity is increasing, particularly in North Africa. In Egypt, 26% of the men, 48% of the women are obese. And in sub-Saharan Africa, particularly South Africa, where 13% of men and 42% of females are obese. So with this increasing prevalence of obesity, diabetes mellitus, and metabolic syndrome, there's a potential increased risk for development of fatty liver. But there are geographic variations. If we look at this map, we see the global prevalence at 24% and an estimated prevalence of NAFLD of 13% in Africa. However, if we look at the intake of calories, we see in the north and in the south high intakes of greater than 3,500 kilocalories per day. And we need to remember within the rest of Africa, early malnutrition and growth stunting is associated with an increased risk of metabolic syndrome. And this is then further exacerbated by increasing urbanization in adult life and associated change from a traditional diet high in fiber to a more Western diet high in calories, animal protein, saturated fat and sugar, and thereby we have almost a double hit promoting metabolic syndrome. Data is scant though. Is there really a lower prevalence as is seen in African Americans, or is it under-recognized? In terms of Nigeria, its incidence is as high as 16% in diabetics and 5% in non-diabetics. And in South Africa, a study showed that 47% of diabetics had evidence of NAFLD, 69% were of mixed ancestry. Of those, 36% of those with NAFLD on biopsy had NASH, and 70% advanced fibrosis. And in Sudan, 20% in a small population-based study, and 50% in diabetics. And in Egypt, in school children, 16% were assessed as having NAFLD. But I think there are ethnic factors that play a role. This is a study from South African women, which showed in African women that the prevalence of liver steatosis was much less than in Indian and Caucasian, and subcutaneous fat seemed to be a predictive factor. That was despite them having higher BMIs, whereas in Indian Caucasian, the metabolic syndrome played an important role. So moving on to infections, schistosomiasis. This affects 240 million individuals worldwide, mostly in sub-Saharan Africa. As we know, this can result in significant problems with hepatosplenomegaly, complications of portal hypertension with life-threatening varicose bleeds. This obviously requires access to gastroscopy and varices eradication programs, which are not always available. It's often associated with hepatitis B and hepatitis C and co-infections. And in sub-Saharan Africa, it's estimated that 100 million school-aged children require treatment. Fortunately, with the introduction of mass drug administration programs with praziquantel funded by pharma and international aid groups, now 56 million in 27 countries are receiving praziquantel, and most people in endemic areas will fortunately receive more than one treatment during their lifetime. If we look at this map, we see the burden of schistosomiasis in Africa. The black dots indicate countries where mass drug administration programs have been implemented. But I think if we're going to be looking at eradication, we need to look at what Egypt has done with using eradication programs with improvement of water supplies, sanitation and hygiene, killing of mollusks, in addition to implementing praziquantel. But this will require infrastructure, particularly in rural areas, for implementation. Soil-transmitted helminths, this accounts for 273 million individuals in sub-Saharan Africa, but only 54% are actually having treatment coverage. And if we look in more deeply with Ascaris lumbricoides, this is associated in tropical and subtropical areas with poor sanitation and hygiene, with fecal contamination of the soil, so often picked up by children. And hepatic ascariasis tends to affect adults, females more than males, and they tend to present in their mid-30s. And they have a whole range from biliary colic, which shows here with worms in the common bile duct, and this may require FRCP to actually extract the worm, and once again, these facilities are not readily available. You can get acute cholangitis, acute acalculous cholecystitis, liver abscesses, and then there's a very interesting entity of recurrent pyogenic cholangitis, which has been reported from South African children, where you have intrahepatic stones and secondary sclerosing cholangitis, eventually leading to biliary cirrhosis. And it's thought that dead worm fragments and ovoform nidus for stone formation. And then finally, this entity of membranous obstruction of the IVC. This is an inclusive lesion of the IVC, usually complete, but occasionally can have a small central opening. It tends to be located close to the entrance of the IVC into the right atrium, or just below the level of the diaphragm. It's usually a membrane of variable thickness, but can be a fibrotic occlusion of variable length, and these individuals present with chronic venous congestion and centrilobular fibrosis of the liver. In terms of etiology, this is uncertain. Is it a congenital vascular anomaly? But these patients tend to present in adulthood. So is this actually acquired? Is it a result of organization of a thrombus in the hepatic portion of the IVC? And in Africa, many of the studies have been associated also with a high incidence of TB. Southern Africa has a very high incidence of 4% in sub-Saharan black Africans, and the risk of HCC ranges between 4 and 23%, with the highest in South African blacks with a risk between 40 to 48%. And once again, this requires sophisticated imaging to be able to diagnose this. So in summary, the clinical spectrum and burden of liver disease is affected by both socioeconomic and climatic factors. Unfortunately, there's a lack of vital registration data to accurately assess the burden of liver disease in Africa. And we need to improve education, clinical awareness, and public health resources for the management of liver disease and its associated complications. National governments, international aid groups, NGOs, and pharmaceutical companies will all need to play an active role in combating liver disease in Africa, bearing in mind that many of these are potentially preventable, eminently treatable, and even curable with present-day therapies. Thank you very much.